Good afternoon, ladies and gentlemen. My name is Saina. I'm one of the cardiothoracic trainees from UK. I would like to thank the Society for the opportunity to present our data from Liverpool Heart and Chest Hospital, and that is on looking at the outcome of the radiofrequency ablation for atrial fibrillation in patients undergoing cardiac surgery. Preoperative atrial fibrillation has been shown that affects survival postoperatively. There is concrete evidence that preoperative AF is an indicator of the mortality postoperatively. It has also been shown that AF treatment can restore sinus rhythm successfully in about 70 to 97% of the cases. Therefore, it is expected that treatment of atrial fibrillation can improve the survival, and that was the question of our study. Does restoring sinus rhythm improve the survival after the operation of the cardiac surgery in these patients, or the effect of AF has so negatively affected the heart and the cardiomyopathy as a result of long-standing AF can affect the survival that restoring sinus rhythm wouldn't really change the survival. Therefore, we aim to assess whether RF ablation during cardiac surgery in these patients improves the outcome. This is a retrospective study on prospectively collected data looking at over 10,000 patients for a 5-year period between 2005 and 2010. We looked at the patients who had concomitant ablation and other cardiac operations. Overall, there were 1,384 patients with preoperative atrial fibrillation, or 13% of the cases, and of these group, only 158, or 11.5%, underwent concomitant ablation. We had strict criteria for ablating the patients based on the guidelines: age 75 or less, persistent or permanent AF for less than 5 years, and also atrial dimensions of 5.5 centimeters or less. Statistical analysis was performed. We used a propensity matching, and we matched the groups with 1 and 2 matching for preoperative characteristic and operation and the procedure type. Overall, 130 patients remained in the ablation group, and that they were compared with 226 patients who did not receive ablation. Deaths occurring over time were measured with Kaplan-Meier survival curves, and a p-value less than 0.05 was considered to be statistically significant. In this busy slide, we're showing the characteristics of the patients before matching. The age of the patients in the ablation group was these groups were significantly younger compared to the patients who did not receive ablation. However, these patients had considerably less comorbidities such as myocardial infarction, diabetes, renal dysfunction, DVT, and the number of 3-vessel disease and redos were also less. There were less number of patients with poor ventricular function in the ablation group, and also their logistic euro score was significantly lower. The number of the rheumatic heart valve disease in this group was also considerably lower. After matching, these differences became insignificant. Also, when looked at the operations, number of the cases in the unmatched group, there were less urgent cases in the ablation group, and there were differences between the number of the mitrals that were performed and the off-pump cases. They were also taken into consideration when we matched for these characteristics. After the induction of the anesthesia, all the patients received a TRE probe, and we performed bipolar radiofrequency ablation using AtriCure from Cardioplegic Limited with an additional pen in some cases, and we performed ablation twice for each side. We performed the ablation around the pulmonary veins, the connector line between the pulmonary veins, and from left pulmonary vein to the left atrial appendage, and also right pulmonary vein to the mitral valve, and also around the left atrial appendage. The left atrial appendage was closed in all the cases, in the mitral cases from inside, and in other cases from the outside. Postoperatively, these patients were started on IV amiodarone for 24 hours and followed by oral amiodarone for 6 weeks. All of them were warfarinized, and at the time of discharge, 19% remained in AF, and unfortunately, on outpatients clinic, 33% were in atrial fibrillation. Looking at the results and the outcome, bypass time was significantly different before and after matching for the preoperative characteristics, and it remained between 10 to 20 minutes longer longer. However, rest of the characteristic and rest of the complications were similar between the two groups. CKMB was significantly higher in the patients who received the ablation before and after matching for the preoperative characteristics. Looking at the outcome, ICU length of stay and postoperative length of stay did not show any difference before or after matching, and the hospital mortality was significantly higher in the patients who did not receive the AF before matching for the characteristics, and yet again they did have more comorbidities, but it was the difference was insignificant after matching for the preoperative characteristics. Looking at the mortality rate, in 5 years, patients who did receive ablation had a better survival rate. And looking at this graph, when unmatched, patients who had the ablation did show better survival rate, and when we matched for all those comorbidities and the type of the operation, this difference was still quite remarkable. In conclusions, ablation was performed only in just over 11% of the patients in our department, and we've shown that RF ablation did not increase postoperative complications, but it did decrease all-cause mortality in short and mid-term. Therefore, we believe that there should be a low threshold in ablating the patients, and that we should have better documentations of the patients who do have atrial fibrillation, and in future, randomized controlled trials should be performed to establish the effectiveness of ablation with cardiac surgery. Thank you very much.